Hello everyone, welcome to the Shriver Center webinar, the Affordable Care Act, Poverty and Asset Building. My name is Alex Hoffman and I'm the Asset Opportunity Vista here at the Shriver Center, and today I will be moderating the event. The Sargent Shriver National Center on Poverty Law provides national leadership in advancing laws and policies that secure justice to improve the lives and opportunities of people living in poverty. We have three program areas: advocacy, where we do local and national policy advocacy and litigation on poverty-related issues; communication, where we provide news and information to the legal and public policy community. Our flagship publication within the communication program is the Clearinghouse Review. We also have a training program in which we provide on-site and online skills-based training to members of the legal aid and public interest law community nationally. The Asset Opportunity Unit takes action against poverty by advocating for policies that expand asset building opportunities for all people. If you experience any technical difficulties, contact 312-368-1168. And I urge you to ask questions at any time during the presentation using the control panel, the questions tab, and you can expand it by clicking the plus sign to the left of the question tab. In order to set the stage for the discussion on poverty today, here is a really oversimplified view of poverty in America. It's poverty according to the U.S. government's definition, which is based on income, which shows that about 15 to 16% of the U.S., depending on which measure you use, the federal poverty line or the supplemental poverty measure, that's 15 to 16% of people in the U.S. are living in poverty. But in reality, as many advocates know, way more than 50 million people are struggling with financial issues and poverty in America. Now a really quick history of healthcare policy in America to set the stage for the conversation about the Affordable Care Act. In 1929, Baylor introduced the first health insurance program, which was really just a hospital insurance program, and later it became Blue Cross. In the 1930s, FDR attempted to enact a state-run universal health care program, but in 1935, FDR dropped his plan to have this universal health care so that he could pass Social Security. In 1943, the Wagner-Murray-Dingle bill, which would have instituted universal health care, that failed. And then in 1948, President Truman was reelected on a mandate to institute a single-payer health care system, but failed due to fears that it would lead to communism. Sound familiar? In 1956, the military Medicare was enacted, which provided health insurance for members of the military and their dependents. In 1965, President Johnson signed Title 19 of the Social Security Act into law, which created Medicare health insurance for the elderly and Medicaid health insurance for low-income people. In the 70s, Ted Kennedy worked on creating a single-payer system. That never panned out. And in 1974, President Nixon countered Kennedy's proposal with a slightly more conservative but still universal health care program, which also failed. In 1986, COBRA was passed, allowing people who lose their jobs to continue their health plan for 18 months. And in 1993, Bill and Hillary Clinton attempted to create universal health care, and that failed. In 2003, the Bush administration created a Medicare prescription drug program known as Medicare Part D, which created the problematic donut hole, and also established health savings accounts. In 2006, then Governor Romney of Massachusetts signed into law Massachusetts health reform, which served as a precursor to the 2010 Affordable Care Act, which we're going to discuss today. So I will let the panelists go into details about the ACA. So without further ado, I'll introduce the panelists. We have Alan Weil, the Executive Director of the National Academy of State Health Policy. Reid Cramer, Director of the Asset Building Program at the New America Foundation. And David Himmelstein, Professor of Public Health at the City University of New York at Hunter College and a visiting professor of medicine at Harvard Medical School. Prior to joining the National Academy of State Health Policy, Mr. Weil served as director of the Urban Institute's Assessing the New Federalism Project, one of the largest privately funded social policy research projects ever undertaken in the United States. Alan Weil previously held a cabinet position as executive director of the Colorado Department of Healthcare Policy and Financing, and was health policy advisor to Colorado Governor Roy Romer, and was assistant general counsel in the Massachusetts Department of Medical Security. So let's welcome Alan Weil.
Thank you, Alex. As my slides come up, I appreciate the opportunity to join in this webinar. My organization, the National Academy for State Health Policy, is an independent, nonpartisan nonprofit that works with states to help them improve health policy and practice. I'm going to give a very quick bit of background information on who is affected by the Affordable Care Act, and then a little bit of a perspective on how that coverage affects opportunities for asset building, which is the focus of the webinar today. I begin with just an overview of sources of insurance coverage by income group. What you see at the bottom of this slide from the Kaiser Family Foundation is that about a third of non-elderly Americans living in poverty are without health insurance. That's the gray on the bottom right. Medicaid is the largest source of coverage for those under poverty, but leaves many out. But do note that there is some private coverage even for those in the lowest income categories. As you move up to 1 to 200% of poverty, there's a significant decline in Medicaid and significant increase in the availability of private, predominantly employer-sponsored coverage, but we still see almost 1/3 of people in the near poverty category without health insurance. And of course, the prevalence of employer coverage increases as income climbs and the incidence of uninsurance decreases. This is a different way of looking at the uninsured, simply asking what is the composition of those without health insurance. And what you can see in the orange slices on the right-hand side is that basically half of the uninsured are in the income category below 138% of poverty, which is the Medicaid expansion threshold under the Affordable Care Act. About 40% are in the dark blue, which is the category of those eligible for subsidies in the health insurance exchange, and approximately 10% have income that exceeds eligibility for any subsidies from the federal government. The Congressional Budget Office has estimated where people will get their health insurance in 2016 and compared that to where we would be without the Affordable Care Act. And in the time that I have with you, I'm going to focus on 3 segments of the population on the right-hand side. The first that is quite worthy of note is that according to the CBO estimate, 31 million people will remain without health insurance even under the Affordable Care Act. Now that number went up as a result of the Supreme Court's decision that permitted states to decline the Medicaid expansion. There would have been more of a significantly larger reduction in the number of uninsured had the court not reached that conclusion. There's not, unfortunately, a lot to say about the fate of those who will remain uninsured. That fate will be similar to what it is today, which means very limited access to care, reliance on charity and safety net providers. The second area of focus is Medicaid. In the bottom to the left of each pie chart, you can see, again, the Congressional Budget Office anticipates Medicaid coverage to expand from 34 million under previous law to 45 million under the Affordable Care Act. Again, this is taking into account the fact that states are not required to expand Medicaid because of the court's decision. Now, I should emphasize that the Congressional Budget Office's estimates are just estimates in all respects, but particularly with respect to the Medicaid expansion. The map I'm showing you here from the Kaiser Family Foundation shows what the governors of the 50 states want to do with the Medicaid expansion, but it is still very much in play in a handful of states. Somewhere, my estimate is somewhere between 20 and 25 states will end up doing the expansion effective January 1st of 2014. I would anticipate that another 5 or 10 will join in a year or so later, but again, I just have estimates as well. We really don't know where this will land. You can also note, of course, that there are large states where we have large numbers of uninsured that are still very much in play. In Texas, where the governor opposes the expansion, in Florida, where the governor favors the expansion, the legislature is unlikely to go along with the governor in Florida. The third category that I'm going to focus the balance of my time on is the population eligible for subsidies through the health insurance exchange. As you can see in the light blue on the right side of the pie chart, the Congressional Budget Office estimates about 24 million people will obtain their coverage through the health insurance exchanges. Now, I assume those of you listening are generally familiar with the structure of the Affordable Care Act, building on a platform of Medicaid coverage. People between 133 and 400% of poverty, if they do not have affordable coverage available through their employer, are eligible for two kinds of subsidies to enable them to purchase health insurance through new health insurance exchanges. The subsidy that has received the most attention and is the easiest to understand is a subsidy towards the premium. It's a tax credit that can be received in advance, like the EITC, that can be used to reduce the effective cost of purchasing insurance in the exchange. The more complex and less discussed subsidy is a subsidy toward cost sharing. Those who are at the lower range of the 133 to 400% of poverty will also face lower deductibles, lower copayments, and lower out-of-pocket maximum. Unfortunately, the structure of the lower cost sharing is it's a number that has not yet been translated into exactly what benefit packages are going to look like. So it's very hard to say what the cost sharing is going to be for people who are eligible for cost sharing subsidies, except to state that it will significantly reduce their out-of-pocket costs. So what I've attempted to do, building on some work I did some time ago around effective marginal tax rates in health subsidy programs, is to give you a picture of how this all plays out from the perspective of marginal and average tax rates, which are two critical components for thinking about asset building. On this slide, I've simply shown you for an individual what the out-of-pocket health care premium costs are going to be under the Affordable Care Act. At the lower income levels, but around poverty, you are capped at the premium being 2% of your income. As you approach 400% for an individual, 400% of poverty, that goes up to 9.5% of your income. So the premium contribution required by an individual who does not have coverage through an employer is on this line. I've now added the cost for someone who is at the maximum point of cost sharing. This would be someone who either has a very significant acute episode or a very expensive chronic condition that basically forces them to max out all of the benefits available to them under the health insurance plan. And these out-of-pocket maximums are capped in the law, and when you add them to the premium, you get the purple line, which I've presented here. I do want to be clear that a relatively small share of the population is up on the purple line. I'm simply trying to show you the bounding between someone who has no health care costs and only pays premiums and someone who has very high health care costs and pays the maximum cost sharing. So in the final slide for you, I've just added 3 lines to give some perspective. The red line is a 10% tax rate, the green is a 15%, and the blue is a 20% tax rate. And I want to look at these lines from 2 perspectives. The first is the effective marginal tax rate, which is essentially the work disincentive. A high effective marginal tax rate, which means a high slope, means that earning additional dollars in salary doesn't actually yield any better standard of living. And so you want to avoid high marginal tax rates. What you can basically see is that the marginal tax rates hover for someone with very low health care costs. They are what the premium sliding scale is. They go from 2% up to 9.5%. For someone with very high health care costs, the marginal tax rates are higher. There are some important cliffs to keep an eye on, or notches, at 133% of poverty, where the premium contribution that the individual has to make goes up quite dramatically. And at 200 and 300% of poverty for someone with high health care needs, they're going to take any increase in income will just be eaten up entirely by increase in out-of-pocket payments. So that's the marginal tax rate, which is looking at the slope. The other way to look at it is the effective total tax rate, which is to not look at the slope but look at the point on the line. And what you can see here, again, is that for low healthcare users who are just paying premiums, their total tax rate is going to be ranging from 2 to 9.5% of income. But the total effective tax rate for someone with high healthcare costs hovers pretty close to that 20% line all the way from poverty up to 400% of poverty. What that effectively means is that very high healthcare utilizers, individuals, will have to contribute about 20% of their income toward their total health care costs across this entire income range. Now, of course, that's lower than it would be if they were uninsured, and it's higher than they would be if we had a much more comprehensive product. I do want to clarify just 2 points in closing. One is that with healthcare consuming 1/7 of the economy, as you move up into the 2, 3, 4, and particularly 300 and 400% of poverty range, you're hitting median income. And it's really quite difficult to pay for 1/7 of the economy without expecting some significant contribution from people as you start hitting the heart of the income distribution. So although these rates are high, expecting some form of contribution, I think, is understandable. And the other closing observation is simply to say that this is for individuals and is fairly stylized. It gets far more complex for families because you have to look at different subsidy levels for children than for adults, and different benefit packages for children on Medicaid and on the Children's Health Insurance Program, on employer coverage. So do take this just as a starting point for a conversation. I hope it does give you a sense both of who's affected by the law and what some of the implications are for those who are trying to build up their assets. Thank you.
Thank you, Alan. Next, we have Reid Cramer, who's the director of the Asset Building Program at New America Foundation. His work has provided analytical support for the development of a range of policy proposals, including the Aspire Act, a bipartisan proposal to create a savings account for every newborn child in America, AutoSave, a unique model that automatically diverts payroll into flexible savings accounts, and the Savers Bonus, which provides a targeted incentive to contribute to savings products at tax time. Prior to joining New America, Dr. Cramer served as a policy and budget analyst at the Office of Management and Budget, where he helped coordinate policies on housing, savings, economic development, and program performance.
Great. Well, pleased to be with you today. This is really a great and timely topic. Let's see, I'm supposed to show my screen here, and I think my slides will be up. Really, in exploring the links between the Affordable Care Act and asset building and poverty, I want to broadly consider the connection between health and wealth issues. I work at a policy think tank here in Washington, D.C., and we really do look at the world through an assets perspective. You know, beyond income, economic prospects are influenced by a range of factors, including the extent to which families can access and deploy a wide range of resources and assets. And the theory is that people just don't spend their way out of poverty, but they move forward in their lives when they're able to save and then command resources. So if we take a look at the family balance sheet, you know, we can see whether or not families have a positive net worth, whether there are assets there that they can leverage and deploy. And the family balance sheet gets pretty complicated. There are assets held in many different forms. And then there's debt. And debt and assets coexist on the balance sheet, but it's not always easy to categorize. That there's good debt and bad debt. So we can look at housing debt sometimes is useful because it helps families access very advantageous services and neighborhood amenities in addition to shelter. But you can also have housing debt that's too high of a burden. You can think of the same thing with student loans, where you could use that debt to increase human capital, but it can also be debilitating if it doesn't lead to a good paying job. So good debt and bad debt is out there. And really then there's medical debt. And a large percentage of the population, especially that doesn't have health insurance and has rising health care costs, this leads to a situation where medical debt has become a huge problem, and for many years very much an underappreciated problem in creating some of the economic insecurity. In fact, it's really one of the leading causes of insecurity and personal bankruptcy that has been experienced. It really drains savings, it drains assets, and it undermines the wealth creation and the asset building process. A bunch of statistics are up there on the screen. In 2010, we had 44 million working-age American adults who had medical debt or medical bills they were paying off over time. Those that have medical debt find it very difficult to access needed health care, or they're able to pay other bills. So it leads to financial stress, mental stress, a lot of interrelated issues. We had 29 million Americans that used up their savings trying to pay off medical debt. Another 22 million were unable to pay for basic necessities such as food, heat, or rent. And medical debt's been identified as a factor for tens of thousands of home foreclosures that have occurred kind of in the wake of the Great Recession. And the consequences then get amplified as debt gets reported to credit bureaus. And we had approximately 30 million working adults that had been contacted by collection agencies annually for unpaid medical bills. When the Federal Reserve has studied this, they found that more than half of the accounts in collection and on credit reports were medical in origin. So it's a huge issue. And we've also found disparities among racial and ethnic groups where minorities have reported a much higher percentage of medical collection accounts on their credit reports. So this is where the Affordable Care Act comes in. Medical debt has a lot of consequences that impact both health and wealth. And my main point here is going to be that there is a health-wealth connection. The CARE Act puts in motion a number of efforts that build on this connection and improve the financial security of families across the country. For instance, already we know that young adults can stay on their parents' plans until they're 26 and can improve the financial security of families across the country. They're able to purchase insurance through these healthcare exchanges. That's what's being set up now. And there's a number of other mechanisms that are being put into place by the law. And building on the work of my colleagues, I want to focus on 3 ways that the CARE Act bridges this health-wealth divide. First is really through expanding health insurance coverage. Access to health insurance improves health outcomes. We know that people who are healthy, who are able to work, provide for their families, and contribute to the economic and social life of their communities. And just as much as Medicare did for seniors and the disabled more than 4 decades ago, the CARE Act can reduce the financial burden of paying for health care that a lot of middle and lower income Americans face. So the goal of the policy was really to level the playing field by bringing up the floor so those who can't afford coverage were able to purchase it. And health insurance is really just key to strengthening the safety net that we have out there in policy, one that has a lot of holes in it. But this is a major hole that can be filled in our social policy system. It really is a keystone policy, which can make many other programs work more effectively. The health-wealth connection is also strengthened by improving coverage quality and reducing medical debt. There's a number of provisions that have the potential to make an impact here. Some of them include consumer protections, caps on eliminating caps that are on insurance benefits, and ending the ability of insurance companies to deny coverage based on pre-existing conditions. That's what's gotten a lot of attention. But the third manner that I want to focus on with this connection can be made through simplifying eligibility for public assistance programs. I mean, right now, the states are designing the health exchanges that are going to create the means by which families access services. And this may begin with insurance purchases, but it also has the potential, and I think in a number of places will, extend to other public benefit programs. States should be expected to design consumer-friendly interfaces and also to reduce barriers to other public programs through simplifying rules. The exchanges can and they should function as almost one-stop shops to access other public benefits. So the CARE Act is likely to have a very powerful impact on state programs by creating this central portal to other services. And to make this work, the state should be looking to use technology to make the enrollment process far more consumer-friendly than it's been in the past, and to streamline eligibility for other programs. Say a little bit more here. The broad idea is that some individuals who are going to become newly eligible and apply for health coverage as a result of the CARE Act, they're going to also be eligible for things like SNAP and food stamps and child care subsidies and energy assistance. And data matches can help those newly eligible people enroll in other programs for which they qualify. So a simplified and coordinated eligibility rule system structure that the states can create can make this process much more effective. So it also could work the other way, where existing data around current SNAP participants could potentially be used to automatically enroll newly eligible people in Medicaid and reduce the administrative burden that would come with a flood of new applicants. There are some incentives for technological upgrades that are embedded in the law. For example, I think it's until 2015, Medicaid and other federal grants will pay more than 90% of the cost of IT investments that are done on the part of the states in setting these things up. But to qualify for the funding, the eligibility systems must meet some standards for a seamless, kind of consumer-oriented, first-class experience that can determine like eligibility in real time while people are waiting. And applicants could be offered the choice of then having their information shared with other state agencies so that they could immediately begin assessing eligibility for these other programs. This could be done so no additional information is needed. The CARE Act also has eliminated Medicaid asset limits for all households except the elderly and disabled as of next year, I think. And so the states don't have to count up all of family assets before enrolling them in the program. And this is the kind of approach that I think has the potential to help create some momentum to lead to reforming the asset limit rules in other programs across that the states administer, such as TANF, and it's already happened in programs like SNAP. So really my broad point being that information sharing and not just eligibility screening is really a key. Many people aren't going to complete applications, and it's a better approach if they're just people are deemed eligible, so that you're automatically qualified for a program if you qualify for another one, and then on top of that, more ideally, you're automatically enrolled. And finally, there's other opportunities for verification of information through data matches, and to use this information to streamline renewals so that information can kind of pre-populate forms when people are having to kind of reapply. So there's a lot of different agencies where this is relevant, connecting IRS to HHS and Social Security, but also a lot of the state agencies that are administering programs. So the bottom line here is that the CARE Act is really a significant opportunity to reform the functioning of a much larger welfare system. And the healthcare exchange is really they're a key portal to facilitate access to a number of other public assistance programs. So getting them up and running is a significant challenge and an opportunity for the states and for the federal government, and for also consumers and advocate groups to kind of provide an oversight and watchdog of states as they unveil their exchanges. A number of resources are available from some organizations that have done some excellent work. Here's some references for you. Excellent work being done by CLASP, Center for Law and Social Policy, and some others. So very key time ahead where people can be monitoring how the states unveil these exchanges that they're setting up. So thank you.
Thank you, Reid. I now want to welcome Dr. David Himmelstein, Professor of Public Health at the City University of New York at Hunter College and Visiting Professor of Medicine at Harvard Medical School. Dr. Himmelstein practiced primary care internal medicine at the public hospital in Cambridge, Massachusetts for 28 years. He has authored and co-authored more than 100 journal articles and 3 books, including widely cited studies of medical bankruptcy and the high administrative costs of the U.S. healthcare system. His 1984 study of patient dumping led to the enactment of the Emergency Medical Treatment and Active Labor Act, known as EMTALA, the law that banned that practice. He co-founded Physicians for a National Health Program, whose 18,000 members advocate for nonprofit single-payer national health insurance. Please welcome David Himmelstein.
Thanks for having me here. I think I've got my slides up on the screen. I have no relevant commercial financial interest, but as you've noted, I have clear interests in health policy debates that arise from my activities as a clinician at the public hospital in Cambridge for many years, and more recently I now am a clinician in the South Bronx in New York at a safety net clinic, and a longtime advocate for single-payer national health insurance. And that very much colors my perspective on the ACA, and that perspective is that we didn't go nearly far enough with this reform. Our healthcare costs have risen rapidly over the years in the U.S. We've had a slowdown the last few years. This slide I used to illustrate almost any point in health economics because it has no labels and never goes out of date. But the evidence is quite strong that we will have a resumption in rising healthcare costs quite soon. And that's really the basis for our unaffordability crisis in the healthcare system. The number of uninsured, of course, has risen through the years in the U.S. and risen because the number of people with private insurance had been dropping. Here's the trends in the percentage covered by private insurance. And the only reason we didn't have a much more rapid increase in the uninsured over the past few decades is because of the really quite striking expansion of Medicaid during that period. So government has been stepping in, and the ACA is a continuation of the kinds of policies we've had. It's a more vigorous pursuit of those policies, but really along the same lines of the kinds of things we've been doing. Just to note that we are used to thinking about the uninsured, but much less used to thinking about the underinsured as a major problem in our healthcare system. Virtually none of us have fully complete coverage for nursing home care. If you're sick enough, long enough, you'll be bankrupted and then eventually qualify for Medicaid. But almost no Americans have full coverage equal to what people in other nations would expect from a healthcare system. So underinsurance is in fact very widespread. This is data from the Commonwealth Fund. The light blue is the number of people who are adequately insured, at least by their measure. And the yellow bar, the yellow pie slice is the number of uninsured, and that's grown modestly during this 7-year period. But the purple there is the most striking growth, and that's the number of underinsured. And we've had a very substantial growth there. And part of what we'll see with the ACA is a change from uninsurance to underinsurance. We know that underinsurance has substantial consequences. This is some data about patients who come into an emergency room having suffered a heart attack. And the point here is that while the uninsured are 38% more likely to have delayed coming into the emergency room because they're afraid of the costs, the underinsured are 21% more likely than the insured to come in, to delay coming in for care. So not as bad as uninsurance, but clearly substantial problems. We know delay leads to higher death rates, so undoubtedly mortal consequences here. We know that many insured patients, and more of them, are abandoning prescriptions at the pharmacy after they've handed the prescription into the pharmacist and gotten approval from their insurer to pick it up. And presumably this is because they face co-payments and unaffordable costs after bringing the prescription in. So by 2009, 9.2% of brand name prescriptions were abandoned at the pharmacy, and this is among insured people. The work on medical bankruptcy, I think, has already been mentioned by some others. Some studies that we did with then Professor Elizabeth Warren. I should note that Elizabeth takes no responsibilities for things that I say. We surveyed people in bankruptcy courts around the country, and medical costs were or illness were a major contributor to, back in 2001, about half of all personal bankruptcies. When we resurveyed In 2005, it was up to 62%, about 2 million medical bankruptcies a year. And the most striking feature at the bottom of this slide, and that is that 76% of the medically bankrupt had coverage at the onset of the bankrupting illness, and most of them had coverage throughout the bankrupting illness. And here's the insurance status of people who filed for bankruptcy because of medical problems, and you see that 22% of them were uninsured, but 60% of the medically bankrupt had private insurance. And what we're doing is heading towards a system where we will have much more private insurance and much more Medicaid, but we fear not much less in the way of medical bankruptcy. This data not from our study, but from others. Among cancer patients, the yellow bar is patients who were insured. 5% delayed or went without needed care because of cost. 22% of insured cancer patients used all or most of their savings to cover the cost. 9% received a collection call about a bill from their cancer therapy, and 7% were unable to pay for basics like food, heat, or housing, and 3% actually filed for bankruptcy in the wake of their cancer. And again, this is just among those with insurance. I think Reid has already talked some about the enormous numbers of problems that the Commonwealth Fund has found in their surveys about people having problems paying bills and getting collection agency calls and paying bills over time. The point of this slide is not only are those large, but they're rising between 2005 and 2010. And the striking thing in these surveys, not illustrated on this slide, was large numbers of people with insurance have these problems as well. And of course, this comes in a setting of enormous financial problems more generally in our society. Here's the pattern of income growth in the third quarter of the 20th century. And the bottom 20% of the income distribution had the most rapid income growth, 138% during that 28-year period. The top 20% also had a substantial growth, 99%, but all parts of our society were seeing their incomes rise, the poorest rising most rapidly. Here's the more recent pattern, and you see that the bottom 20% actually suffered a loss in income since 1979, while the top 5% had an enormous income gain. And if one graphed the top 1%, it would be even bigger than that, and the top 1/10 of 1% even bigger than that. So we've had this tremendous income polarization in our society, and it's reflected in our health statistics. The yellow line is the life expectancy once you turn 60 of people who are below the median income. And the blue line at the top is the life expectancy at age 60 of those above the median income. And what you see is that whereas in 1972 there was a 1.2-year difference between these groups, we're now more than a 6-year difference between higher income and lower income earners in their life expectancy. So we've had a very great growth, not just in income inequality, but health inequality. Now, in the U.S., I think most people will know we trail other nations in life expectancy, so about 2 years less than most other nations to which we'd compare ourselves. And our costs and health spending are incredibly large by international standards. In this slide, I've shown in yellow the U.S. spending per person in public dollars. And I've included as public dollars not just Medicare, Medicaid, and the VA, but also the tax subsidy for private insurance and also public workers' health benefits. So when government pays for President Obama's health insurance, we consider that a public expenditure, and we've shown it in this slide. And the point here is that at present, the U.S. spends more per person in public dollars than any of these other nations spend on their entire healthcare systems. And of course, all of these other countries have not just universal coverage, but most of them have much more comprehensive coverage than even the best private insurance policy in the U.S. So Canada has first dollar coverage, no co-payments, no deductibles. And these other nations shown here, minimal co-payments and deductibles for most services and much more comprehensive coverage. So we already pay for national health insurance in this country, but we don't get it, is the unfortunate circumstance. It's not that Americans use so much health care that our costs are so high. We have fewer doctor visits than in most other countries. Here's the number of doctor visits per person. U.S. is at the bottom of the scale. Number of hospital days that we use per person is low by international standards. We don't even get many bone marrow transplants and many other kinds of high-tech care compared to many other nations. What we do get an enormous amount of is administrative costs. So for every man, woman, and child in the country, we spend about $1,300 more than they do in Canada. That's about $400 billion a year in excess administrative costs compared to a single-payer system. And unfortunately, one of the things we're doing with the Affordable Care Act is we're adding even more administrative costs, and I'll get back to that in just a minute. Now, the Affordable Care Act, the LANCET, the most respected British medical journal, in their cover when it was passed, summarized their view. They said the healthcare reform process exposes how corporate influence renders the U.S. government incapable of making policy on the basis of evidence and the public interest. I spent many years in Massachusetts and was closely familiar with what we called Romney Care there, very much the model for Obamacare, and very much not what we might want to see as a single-payer system. In Massachusetts, there was a substantial decrease in the number of uninsured. About half to two-thirds of the uninsured got coverage. But when the Boston Globe surveyed the population, they found that 14% of people in Massachusetts reported that they had medical debts accumulated in the last 12 months that they couldn't pay. 14% had failed to fill a prescription because of cost, and 9% had avoided or postponed care because of financial problems. Now, I don't want to say there were no advances in Massachusetts. There were, but they were modest indeed. And we resurveyed people in Massachusetts after the implementation of the plan in Massachusetts about their bankruptcies. The percentage of bankruptcies that were medical fell from 59% to 53%. But the number of medical bankruptcies actually had risen. That's because 2009, of course, was during the financial crisis, and the total number of bankruptcies was rising rapidly. So our summary of this data was that there was very little impact on medical bankruptcy in Massachusetts, and as we found nationwide, the vast majority of people in Massachusetts who filed for medical bankruptcy were in fact insured. As has been mentioned, the ACA will leave about 30 million completely uninsured. This map shows the states with population equivalent to 30 million, so we get a clear indication that we've not solved all of our problems in uninsurance. And I want to give a sense of what we're talking about here when we say we're going to get coverage to people. So here's the coverage for someone at 399% of poverty. This is the Kaiser Family Foundation's estimates. So their income would be about $46,000. That's on the right there. The subsidized health insurance premiums that this person would actually have to pay is $4,361. So that's 9.5% of income. That's a very substantial chunk out of income. And down at the bottom, the very lower right, you'll see that out-of-pocket costs can total another $4,167. So this person could well be subject to health care costs of about $8,500 with an income of $46,000, very substantial. When you get just above the ledge where those subsidies are available. So now 401% of poverty. The health insurance premium goes up to $10,193, and the out-of-pocket maximum goes up to $6,250. So $16,000 in health care costs out of a total income of $46,000. So that's why I say for many people getting this coverage, both the unsubsidized and the subsidized through the exchanges, we will be trading uninsurance for underinsurance. Now, the impact of health reform on the underinsured, if you like your current coverage, as the President used to say, you can keep it. What he didn't like to say is that under the law, if you don't like your current job-based coverage, you have to keep it. Or if you don't keep it, you're not eligible for any of the exchange policies. And we've seen what the policies are like. In Massachusetts, they're very similar. Cover, according to the Bronze Plan, about 60% of expected health care costs. Just to give you a sense of what that means, that's a policy with about a $2,000 deductible and 20% co-insurance for the next $15,000 worth of care. I might note that while Alan said that the uninsured will be about the same as they are today, I fear that that's not the case, because we're going to be cutting very sharply the funds that safety net hospitals have been receiving from the federal government to care for the uninsured. And working in safety net institutions, I can tell you we're getting messages from our CEOs that funding is about to be cut for our uninsured patients, so things will be worse off for them. And just to give a sense, even for our Medicare covered patients, Medicare currently covers only about 51% of healthcare services. According to a recent New York Times business section article, that means for a 65-year-old couple retiring this year, the cost of healthcare in retirement will be about $240,000. That's underinsurance by almost any measure. And to give you a sense of what the alternative possibilities are, Canada's Medicare program, they call their universal coverage program Medicare, covers 79% of seniors' total medical expenses. U.S. Medicare covers 51% of our seniors' medical expenses, and yet Canada's program has seen much slower healthcare cost growth over the last 30 years than ours has. Now, if you ask the American people, would you prefer the current health insurance system or a universal coverage program like Medicare, government run and financed by taxpayers? At the time the ACA was under, just before it was under debate, 56% of Americans said they wanted that, and polls have generally shown about that number consistently through the years. On the other hand, here's a picture of the Boston skyline from where I lived in Cambridge for many years, and the two tallest buildings there, of course, are insurance company buildings. And the big problem in getting to the universal coverage that would give us affordable care for everybody is that our insurance companies stand to lose under a system like that, a single-payer system which could give not just universal but first dollar coverage to every American. So I fear, while we've made modest strides with the ACA, before it we had the worst coverage of any developed country and the highest costs of any developed country. And after it, we will still have the highest costs and worst coverage of any developed nation. Thanks very much.
Thank you, Dr. Himmelstein, for that reality check. Sometimes we forget to criticize the policy that we sort of like. I just want to read a question that we received from December. The question is open to the panelists. Are there risks/concerns associated with data matches and sharing in terms of privacy or the idea of Or the idea of tracking poor people. This refers to Reid's presentation about his idea for the user-friendly system for exchanges and other public benefits.
Yeah, I mean, I certainly think there are risks, but a lot of this information is still collected and it's required, but just by different agencies when you're applying for benefits. And I think that the point I was trying to make is that there's some promise and potential for information sharing that could more effectively connect people with public benefits and services that they're eligible for and that they would be interested in receiving and would benefit from. That would still create an additional burden on government to make sure that that information was secured and privacy concerns were protected, and especially the distinction between other kind of health information, personal information, would be very separate. You know, there's another initiative underway, more on the health side, and maybe our colleagues on the panel can address it, but around medical records that have some hope of having an impact on the delivery of care and the quality of care. But I think what we're looking at here on the public benefit side is just information sharing of basic information around income and demographic that could affect eligibility for programs.
Thank you. Another question we received is where is the funding for the ACA coming from, especially for new enrollees in the exchange and Medicaid programs?
This is Alan. I'll take a cut at it. There are a lot of sources, but I think the primary sources you'll find are reductions in anticipated spending in Medicare, which is part of why it led to such a firestorm about whether Obama was cutting Medicare to pay for poor people. And there are some significant new revenue sources targeted primarily at higher income taxpayers. There's an increase in the Medicare tax rate. There's some miscellaneous taxes on devices and tanning beds. There is down the road a reduction in the ability of employers to exclude from taxable income payments for high-cost health insurance plans. So it's a combination of foregone spending in Medicare and new revenues, and if I remember right, it was about half of each.
Just, we should note that the Medicare savings were mostly came from cutting the Medicare Advantage plans payments, and they've clearly been enormously overpaid through the years. It cost much more to care for a patient in the Medicare Advantage plan than if they'd stayed in the traditional Medicare program. So that's where much of those savings have come from. Unfortunately, Secretary Sebelius recently gave them back part of those cuts in their overpayments. So she overruled the Medicare actuaries who said we need to cut the payments to Medicare Advantage plans further and gave them, instead of a cut, an increase. And that's about $7 billion this year alone that she increased those payments.
Thank you. It's now 11:01, so I just want to ask one final question. The question is, what type of advocacy can we do now, today, to make sure that this policy is most effective for fighting poverty?
Well, I think one thing we need to do is to stop the cuts in Medicaid that really seem to be streaming our way. So the administration has announced a proposed rule that would allow state Medicaid programs to start charging co-payments and deductibles even to the poorest of the poor. That's a disastrous policy. They've also indicated a willingness to fully privatize Medicaid programs in Arkansas and probably other states as well. So the administration at this point is really showing an openness to letting states push their Medicaid programs over the cliff. And I think one of the things we need to do is say that that's not acceptable, both at the state level and the federal level.
Thank you. A copy of today's...
This is Alan.
Oh, yeah. Yeah, sure.
I won't try to respond to Dr. Himmelstein's point about the states, but I just want to say that I do think an important point of advocacy right now has to do with actually finding and enrolling people who are eligible for assistance under the ACA, whatever its limitations are. If the people who are eligible for benefits don't get it, it has no value. And obviously there's a lot of work around whether or not states will expand Medicaid in the first instance. So there's plenty to be done at this point.
I think the other thing which I think many people are not aware of is that it's actually the silver plans only that that the poor will get subsidies for their copayments and deductibles. So the bronze plans look cheapest, but the silver plans are the cheapest. So I think poverty advocates need to be aware of that in their communities.
And I'll extend those comments by connecting that outreach imperative to making sure that people, and these systems get set up so that people can be connected to a whole range of public benefits that they're eligible for. And that's going to vary by state, both in the capacity that they have when they kind of construct their exchanges, but being able to kind of look at what their plans are and to be able to critique what they have so that there's some streamlining that can go on, and we can come up with a more effective delivery system, not just for health, but for a whole full range of public benefits.
Okay, great. Thank you to the panelists for their input and great presentations today, and thanks for all of you for joining. A copy of the webinar and presentations and resource materials will be available on our website, and you will receive an email tomorrow, I believe, which will link to that website. You will also receive a survey, a quick survey, and information to subscribe to the Shriver Center for future events. And if you have any questions or want to get in touch with us, contact Karen Harris at 312-368-2007 or Karen Harris at povertylaw.org. Thanks again.